Our next speaker is Dr. Alekos Theologis, who will give us a talk on coronal alignment in adult deformity and optimizing outcomes.
All right. Well, Lionel, Lee, Kyle, kudos to you guys for setting up a fantastic program. And thank you personally for inviting me to give a talk on a topic that I'm very passionate about. This is also going to be a MIS talk, but more on the spectrum of maximally invasive spine surgery. These are my disclosures, none of which are relevant to this talk. So when we talk about the coronal plane, our field of spinal deformity really started with the coronal plane. And in 1966, the Scoliosis Research Society was founded. And at that time, really the coronal plane was the major focus. And over the last 20, 30, 40 years, there's been a huge number of studies and focus on not only assessing the regional parameters, but also looking at what functional outcomes occur from changes in shoulder height, as well as the global coronal malalignment. And initial treatments for coronal deformity really was in the pediatric population, and treatments were focused on that. But in 1980s or so, the pendulum swung, and the sagittal plane really started to take our attention. And the reason for that is because it was being demonstrated that the sagittal plane deformities were major drivers of disability. So from 1980 onwards, we've been focused on which level is the best level to correct with a PSO, lordosis shape, things that Dr. Bervin had talked about with the Rousseli shape, et cetera. But the pendulum seems to be swinging back in the other direction. And why is that? And I think a large part of it is that the coronal plane we're now recognizing does jeopardize functional outcomes as well. But if you look at Glassman's original paper in 2005, in addition to the sagittal parameters, the coronal plane he demonstrated also jeopardized outcomes. You can see here in patients with greater than 4 centimeters of coronal shift compared to those with less than 4 centimeters, they had compromised SRS-22 as well as SF-12 functional scores, both in pain and function. More recently, us in the ISSG have targeted or trying to determine a target coronal realignment goal. And we found that a residual coronal malalignment greater than 3 centimeters was associated with a worse outcome, suggesting a potential coronal realignment goal postoperatively. More recently, 2023, the ESSG, the European Spine Study Group, has actually made this threshold a little bit more narrow and found that coronal malalignment independently affects patient-reported outcomes greater than 2 centimeters, and that disability increases linearly with increasing CSVL. If you realign someone to less than 2 centimeters, this allows for significant improvement in their SRS-22 scores as well as general function scores, SF-36, and it's associated with 3.5 greater fold odds of achieving MCID for the SRS-22. So one take-home point is our coronal realignment targets are CSVL less than 2 to 3 centimeters. You want to also keep the shoulders parallel to the horizontal or the floor. This doesn't mean that you have to make everything straight, but you want to have a balanced correction of the curves. So how do you plan for these operations to achieve appropriate coronal alignment? And the first step is really to define the drivers of coronal malalignment. These come in 2 major flavors. One is intrinsic pathology to the spine, and then extrinsic pathology, so assessing leg length discrepancies and lower extremity deformities that may drive pelvic obliquity. In terms of understanding intrinsic pathology, there's 2 classifications that are important to understand. One is the Bow classification, which is shown here. It's a 3-part system that is dependent on magnitude of coronal malalignment, but also on the truncal shift directionality relative to the cob, the major cob in the lumbar spine, the concavity or the convexity, and we'll go through it here. So type A, as you see on the far left, are those patients who have less than 3 centimeters of malalignment, so they're really not malaligned. Type B are those patients that have greater than 3 centimeters and they have a truncal shift that's ipsilateral to the concavity of the lumbar spine's curve. Type C has a greater than 3 centimeter shift, but it's going to be ipsilateral to the convexity of the lumbar spine, scoliosis. I did a study as a fellow at WashU with Manish Gupta, looking at all of Larry Lanke and Keith Bridwell's patients. This is a unique subset of patients because they have all posterior-based operations. And we looked at defining them preoperatively based on their bowel classification and then seeing how they changed postoperatively. And you can see here that all the patients that were bow type Cs, 67% of them stayed malaligned in the same direction. I'll show you a couple of case examples here. So you can see here this lady with a bow type C who has a truncal shift ipsilateral to convexity, 6.5 centimeters. Pretty significant lumbosacral fractional curve at 40 degrees, and then a main lumbar curve at 45. And they fused this in situ, and you can see that they didn't get realigned. This is a patient who actually got decompensated after correction, and I'll tell you why. So again, a bow type C shifted to the right and a CSVL of 5 centimeters. Significant lumbosacral fractional curve at 40, a main lumbar curve at 50. They did an L3 to S1 T-lift followed by a T4 to pelvis posterior fusion, and they improved both the main lumbar curve and the lumbosacral fractional curve, but they corrected the main lumbar curve too much, and so it made them worse. And we'll talk about why this shouldn't be the approach. And then another patient, and these are deceptive ones, and this will lead into our next classification, which is the Orthopaedic. So this is a patient that's technically a bow type A. They have less than 3 centimeters, so they're not malaligned. But you can see that after surgery, they had a 5-1 T-lift, T10 of the pelvis. And again, they went for a home run correction of the mid-lumbar curve. They improved the lumbosacral fractional curve, but again, there was not a balanced correction of the two curves, and it decompensated them significantly to the right. So that brings us to the Orthopaedic classification, which is a two-part system, and it does not involve magnitude of deformity. It only relates to the truncal shift relative to the concavity or the convexity. So the concave type 1s, as you see on the left there, are the equivalent of the bow type Bs. So their truncal shift is ipsilateral to concavity. And what Orthopaedic has recommended is that all the focus of the surgical correction should be aimed at the main lumbar curve. This is in contrast to the type 2s, which are called the convex types. These are the equivalents of the bow type Cs, and those are the patients with the truncal shift that's ipsilateral to convexity. And in his classification, recommends that all the surgical treatment or the major focus should be correcting the lumbosacral fractional curve. You can see in this classification, A, magnitude is not involved, and B, the type A's of bow can fall into either category. And to understand how to correct these, it's also important to understand flexibility. For the coronal plane, there's a variety of ways to assess flexibility: bending radiographs, standing and prone, push prone radiographs, fulcrum bending, static and dynamic supine, the scout images of a CT scan, as well as a supine MRI. This is a patient of mine. You can see here on our standing radiographs, 10.5 centimeters of coronal malalignment to the left. On the scout CT, the CT scan, you see it significantly improved. So this is quite a flexible deformity, and I think it's important to make your decisions on the supine because that's going to give you information of how they're going to be lying on the table. And I'll show you a case example soon of a patient where the surgical technique will vary based on this. So let's put this to the test. So for the Orthopaedic concave type 1s, or the bow type Bs, again, the main focus should be on the main lumbar curve. You assess the flexibility. If it's flexible, you can do posterior column osteotomies, you can do inner bodies, you choose your pick, whatever you prefer. And then if it's rigid, then these are ones that you should consider doing a 3-column osteotomy on. And then the lumbosacral fractional curve for these patients, in my opinion, it kind of is along for the ride. So this is a patient, Parkinson's disease, very, very severe coronal malalignment, decompensated more than 10 centimeters to the right. You can see it's a bow type B, Orthopaedic type 1. And again, the focus should be in this main lumbar curve. On the supine CT scan, you can replace this with the Scout, but you can see it has air in the disc, so quite flexible, so it does not need a 3-column osteotomy. You could do inner bodies here, whatever your preference is for correcting deformity. And then again, the lumbosacral fractional curve is kind of along for the ride. For this patient, I did a 3-to-1 ALIF to help restore the low lumbar lordosis, but also to correct the bottom portion of the deformity. I wanted to say that at L3-4, I just put morselized graft, didn't put a cage because I didn't want to fix that obliquity at 3-4. And it helped, I think, realign him when I went to the back. And then we did a T3 to the pelvis with a right-sided kickstand rod. And I think overall the coronal alignment was acceptable. This is another patient of mine, Obaid type 1, bow type B. You can see multiple prior surgeries, 4-5 TLIF. She's developed a very severe both sagittal plane deformity and coronal, but we'll focus on the coronal for this one. Again, the focus should be on correcting the main curve. So we assessed the flexibility. In this case, you can see the major driver of the rigidity was this autofusion to the right-sided part of the disc and this lateral osteophyte. So in this case, we chose to do, again, a 3-4, 5-1 ALIF, mainly for sagittal plane. And then we didn't want to do a PSO at this level because if you do an L2 or PSO, it doesn't give you good restoration of your normal shape in the sagittal plane. So we just put an osteotome in the disc, cracked it open, and then you can see how much we distracted through it. And then again, a T3 to the pelvis we had set up a kickstand rod on the right side, but ended up not needing it, and I think overall realigned her respectively. So moving on to the Obaid convex type 2s, so bowed type Cs. Again, these are the problem children. They're the ones that are hard to correct. They either stay malaligned in the same direction or they get worse. And this focus of the surgical correction should be all at the lumbosacral fractional curve. Again, assessing its flexibility, and then you can do your implant of choice. I have a preference for anteriors, but that's mainly for sagittal plane, but also talk about coronal plane realignment. And if it's rigid, then doing a 3-column osteotomy down here is necessary. For the main lumbar curve, one thing I'd like to take away, you guys to take away from this is I would caution against using structural inner body cages in these patients, because if you straighten out the mid-lumbar curve so much, when you go to the back, it's not going to be, you probably can't get them back over. And then these are also patients that I set up a kickstand rod always on that convexity. We did a systematic review looking at improvements in coronal and sagittal alignment, just focused on lumbosacral fractional curve, ALIF, TLIF versus none. And we found that both ALIF and TLIF are better than no inner body at the lumbosacral fractional curve. And there's very limited evidence. It's about 7 studies, and those 7 studies don't have good data. But it does state that ALIF has an advantageous effect on correcting the regional coronal cob of the lumbosacral fractional curve. I have a preference for ALIFs because it helps restore the sagittal plane, helps reduce the pelvic tilt, and I think overall that's better for restoring normal spinal shape. So in the lady that we just talked about, did an L3 to S1 ALIF, again, morselized chips at 3-4, structural interbody cage 4-5 and 5-1. And then we did a T10 to pelvis with the right-sided kickstand rod, and then was able to realign her coronally globally. And now this is a patient where I think assessing the supine radiographs or supine imaging is very important. So this is a lady with myasthenia gravis, so she has a neuromuscular disorder. If you go based on the bow classification, it's a bow type B, and if you go by in the Obaid classification, it's a Obaid type 1. So if you go based on standing radiographs, you'd focus all your correction at the mid-lumbar curve. But if you look at the supine scout CT images, you can see that this patient has more of a trunk shift to the convexity of that main curve, even though she's quote-unquote balanced. So if you did if you tried to correct everything through the mid-lumbar curve, you'd probably decompensate her way off to the left. So in this lady, you want to focus your attention at the lumbosacral fractional curve, which was extremely rigid. And again, main curve, it's already flexible because of her neuromuscular condition, and so it's going to correct with any maneuver you do. So for her, we did a 3-to-1 ALIF, same technique with morcellized chips at 3-4, and then we did a T3 to pelvis with a kickstand rod on the left side, and globally kept her aligned, but regionally both lumbosacral curve and the main curve were corrected nicely. You can see that pre-op, her ribs are on her pelvis, and afterwards, the amount of space on the right side was standing up taller, could breathe better, especially with myasthenia gravis. This was a major consideration. So because I've touched upon and used in many of these cases the kickstand rod, I wanted to walk through with you guys kind of the surgical technique. This is something that there's a lot of different steps to it, and I hope this clarifies things a little bit. So after you do your correction, if you want to use a kickstand rod, what you do is you put the iliac screw in. I haven't done it with the S2AI screw, so I can only speak to doing it with the traditional iliac screw, but you put it on the side of your choice. You then connect around the thoracolumbar junction. I used to use one W connector, but now I use two because there's a lot of force that's put on it, and I just don't want it to slip post-op. And then you run a lateral accessory rod from that extra iliac screw to those W connectors. And then there's a sequence of loosening set screws and tightening set screws. So the green is going to be loose. So ipsilateral to the kickstand rod and distal to the W connectors, you want to loosen those set screws. Proximal to the W connectors, you want to fixate them or tighten them. You want to tighten the iliac screw head. Contralateral to the kickstand rod, you want to tighten it. You want to loosen the W connector set screws on the kickstand rod. You place a rod holder on that lateral accessory rod, and then you distract between the rod holder and the W connectors. And what this effectively does is it pushes down the hemipelvis. It does not push the spine, it pushes down the hemipelvis. So two key things is that when you're setting this up, you want to have a long rod as your kickstand rod, because as you lengthen, it's going to effectively shorten the top relative to the W connectors. And then the second pearl is that on the main midline rod, you want to have that rod long too, because as you push the hemipelvis down, it will effectively shorten that rod relative to your connector to the other iliac screw. When it comes to correcting the lumbosacral curve, both through inner bodies but also with kickstand rod, you can have stretch of especially the L4, L5 nerves causing a neuropraxia. This is a study that Larry Lanke did looking at the distance between the L4 and L5 pedicle to the femoral head. And if you have more than a certain amount, the numbers are here, it increases your risk. Knock on wood, I haven't had any yet, but just keep this in mind that if you stretch it out too much, you can stretch the nerves. I think intraoperative assessment of the coronal plane is very, very key, and I think you should have some way of assessing it. And there's several that you can perform. One is plain radiograph cassettes. Another is an intraoperative CT scan, the O-arm, the 2D long film. And then if you don't have intraoperative CT or these abilities to do a radiographic long cassette, there's the option of using a T-bar. So you can have a rod that you line up with the sourceals. You then run a lateral connector and then connect a domino to it, and then you run a long rod up. You take an AP of the pelvis, and then you get an AP of the cervical-thoracic junction, and the offset from the C7 spinous process to the rod is your coronal alignment. Now, we didn't talk a lot about leg length discrepancies, but this is something that you should assess and understand pre-op so you can compensate or build into it during your intraoperative assessment. So you need to understand what the leg length discrepancy is, the angulation of that relative to the horizontal of the floor, and then you need to make your T or your floor that, and so that angle up from the sourceals will be that degree. So this is another patient who presented with a multiplanar deformity. You can see from a sagittal plane perspective, she has a very severe lumbopelvic mismatch. L4 to S1 lordosis is 0. She had an ALIF at 3-4 to adjust adjacent segment disease, and now she's presenting with a very severe decompensation of her coronal plane to the right. She also has a leg length discrepancy, and we've measured out the angle. It's about 5 degrees. So we want to plan our correction to the horizontal and not to her leg lengths, or not to the sourceals. So for this lady, to correct both the sagittal plane, restore her L4 to S1 lordosis, as well as to restore her coronal plane, we did an asymmetric L5 PSO. We used a kickstand rod on the right and got her within, I think, acceptable range globally. I was happy that we maintained her shoulder height that was level. If you do this, sometimes what happens is that one of the shoulders drops. So I think it's important to both get your global alignment correct, but also your shoulder heights. So in conclusion, coronal malalignment is common. Disability is driven by greater than 2 to 3 centimeters of residual postoperative coronal malalignment. You need to tailor your surgical strategies to the deformity. For the oboid type 1s, which are the equivalent of bow type Bs, these are the concaves. You want to correct the main lumbar curve. For the oboid type 2s, bow type Cs, you want to aim your correction of the lumbosacral fractional curve. And these are the ones that I think all should have a kickstand rod. And then intraoperative assessment is important to optimize postoperative alignment. So thanks a lot.